Good morning, everybody. I now call this meeting of the Human Services Committee to order. I want to thank all of you for being here today, and I'd like to welcome all of my committee members, our testifiers, and everyone who's going to be joining us for what I think is an important discussion. Today, we're going to be examining House Bill 561, introduced by Representative Maureen Madden. This bill proposes to expand the non-narcotic medication-assisted substance abuse treatment grant pilot program to include all FDA-approved medications for the treatment of substance use disorder. And so before we begin, Amanda, I'm going to ask you if you would please take the roll.
Sure. Chairman Williams.
Here.
Rep. Bellman.
Leave.
Rep. Benham.
Leave.
Rep. Serrato.
Leave.
Rep. Giral.
Leave.
Rep. Green.
Leave.
Rep. Harris.
Leave.
Rep. Khan.
Here.
Rep. Kincaid.
Leave.
Rep. Mays.
Leave.
Rep. Otten.
Leave.
Rep. Prokopiak.
Here.
Rep. Rivera.
Here.
Rep. Venkat.
Leave.
Chairman Heffley. Rep. Anderson. Rep. Baseline. Rep. Flick. Rep. Flood. Rep. Hogan.
Here.
Rep. Labs.
Here.
Rep. McKenzie. Rep. Pugh.
On leave.
Rep. Reichard.
Leave.
Rep. Schlegel. And Rep. Weekneck.
Leave. Oh, he's virtual.
Amanda, thank you. I also want to acknowledge that Representative Serrato is here. As we continue to combat the opioid crisis, we recognize that medication for substance use disorder plays a vital role in treatment and recovery. Expanding access to methadone, buprenorphine, Nextrelon in our county jails could help break the cycle of substance misuse and reduce overdose deaths and improve reentry outcomes for individuals returning to their communities. In today's hearing, we will provide valuable insights into the current state of opioid use disorder treatment, access in Pennsylvania jails, and how policy changes, such as those proposed in House Bill 561, could expand access to evidence-based treatment. I want to thank all of our testifiers who will be sharing their expertise. Their perspectives will help inform our understanding of the effectiveness, implementation, and the impact of medication-assisted treatment in our county jails. And with that, I'd like to invite my colleague, Chair Heffley, to share any opening remarks he might have.
Thank you, Chair Williams, and good morning. Good morning to all the members of the House Human Service Committee, both virtually and that are here. This public hearing, Chairwoman Madden's House Bill 561, I want to thank the testifiers for being here today and share their thoughts and perspectives about the potential reversal of the non-narcotic medication-assisted substance abuse treatment grant pilot program. I think we have a lot to learn, and I look forward to hearing from all of you today.
Chair, thank you. Today's public hearing will feature two panels with a range of testifiers offering insights on expanding access to medications for substance use disorder in Pennsylvania jails. Each panelist will have up to 5 minutes to present, followed by a question and answer session. In order to stay on schedule and hear from everyone, I'm going to ask the members of the committee if you would keep your comments compressed, and please refrain from general commentary. And then to our panelists, your written testimony has been shared with committee members, and so I would encourage you to highlight the salient points and to just share any additional insights during your time with us here today. And having said that, I want to invite our first panel to the microphones. Allow me to introduce Dr. Lakita Davis-Jones, Secretary of the Department of Drug and Alcohol Programs. From the Pennsylvania Commission on Crime and Delinquency, Samantha Koch, Michael Lister, from the State Crisis Intervention Program. I'm going to ask you if you'll make your way to the table. Ms. Coach, you're Director of Policy and Planning. When you are comfortable, please make sure you bring the microphones close to you, speak right into them, and you can begin when you are ready. I think your microphone.
All right, got it on now.
There we go.
Good morning. Thank you, Chairman Williams, Chairman Heffley, and members of the House Human Services Committee for the opportunity to testify today. I am Dr. Latika Davis-Jones, and I have the pleasure of serving as Secretary for Pennsylvania's Department of Drug and Alcohol Programs.
Dr. Jones, just bring that microphone a little bit closer. Just bend it down.
All right.
There we go.
Can you hear me better?
Much better.
All right. All right. As I was saying, I am Dr. Latika Davis-Jones, and I have the pleasure of serving as Secretary for Pennsylvania's Department of Drug and Alcohol Programs, also known as DDAP. I applaud Representative Madden's advocacy and partnership on the important issue before this committee today and her reintroduction of House Bill 561 this session. I'd like to begin by outlining what a substance use disorder is and is not. A substance use disorder is a chronic medical condition. It is a disease, a family disease, which we need to normalize and integrate care for. A substance use disorder is not a crime, it is not a moral failing, and it cannot be addressed with a one-size-fits-all approach. Specifically, an opioid use disorder, a challenging chronic relapsing disease, and the overdoses resulting from it continue to devastate the lives of too many Pennsylvanians. And as the state's leading authority on our response to the overdose and opioid crises, I assure you that my department is here to help anyone who is seeking support for an opioid use disorder. But we are asking for the legislature's assistance in removing current barriers that are preventing individuals in county jails from having access to the full range of medications to treat this disorder. We know that an opioid use disorder is a treatable disease, and with the right treatment and supports, recovery is not only possible, it's probable. Heart disease, diabetes, and other chronic conditions are managed through medications and regular healthcare visits. The same holds true for an opioid use disorder. Currently, there are 3 medications approved by the FDA to treat an opioid use disorder: methadone, buprenorphine, and naltrexone. The medical community considers these medications to be the gold standards for opioid use disorder treatment. They help to manage and prevent the symptoms of withdrawal and promote public health through the reduction of infectious diseases such as HIV and hepatitis C by reducing the likelihood of return to opioid use. From day one, I made it a priority to travel to many of your districts to meet with those who are closest to both the progress and pain of the opioid and overdose crises in the communities you represent. Over the past 2 years, I've traveled across Pennsylvania, meeting with community leaders, treatment providers, and people with lived experience. And I've heard time and time again that the exclusion of these gold standard medications creates unnecessary barriers to care, barriers that prevent people from getting the most appropriate medications for their treatment and recovery. Limiting treatment options forces counties to find alternative funding, straining already limited resources. One single county authority administrator shared that less than 5% of the available state funds could be used due to the current restrictions on narcotic medications for opioid use disorder, forcing the county to redirect funds that could otherwise serve the broader community. Right now, county jails in the state are unable to offer access to all FDA-approved medications to treat incarcerated individuals for opioid use disorder. These limitations are often rooted in misinformation or stigma about certain medications, specifically buprenorphine and methadone, despite their proven effectiveness. More specifically, diversion is a concern we often hear as a reason not to expand access to these life-saving medications. While the potential for diversion does exist, evidence shows that the benefits of providers having full access to all three medications to treat their patients in carceral settings far outweigh the risk when appropriate security measures are in place. By allowing county jails to use all three medications for opioid use disorder, we would enable individuals to receive the evidence-based treatment that is best indicated for their medical condition during incarceration and upon release. Most importantly, we would save lives. The risk of experiencing adverse health consequences for someone with an opioid use disorder increases significantly during incarceration. While incarcerated, individuals with an opioid use disorder have reduced access to opioids, leading to a lower tolerance level and an increased risk of overdosing upon release from a carceral setting. Consider this. A recent study found that within 2 weeks of being released from jails, individuals were almost 150 times more likely to die from an overdose than the general public. Another point to consider is one on recidivism. In 2022, less than half of the men who were imprisoned in a jail that offered medications for opioid use disorders were rearrested or reincarcerated, compared to more than 60% of men who were reincarcerated after being released from a jail that didn't offer medications for opioid use disorder. The bottom line is this: the decision about which medication to use should be made by the patient and the prescribing doctor, not by statute or stigma. Expanding our current grant program with the Pennsylvania Commission on Crime and Delinquency, which you'll hear more about in just a minute, to cover all FDA-approved medications aligns with the scientific evidence, best medical practices, and the ethical responsibility to provide the most effective care. I commend the General Assembly and the prime sponsors of this bill for recognizing the importance of investing in medications for opioid use disorder programs. Now is the time to take the next step. Please support House Bill 561 to ensure that every individual in need has access to a full range of medications for opioid use disorder and the evidence-based care tailored to their specific health needs, just as we currently do for individuals requiring medication for mental health conditions. This change will not only save lives, it will strengthen families, communities, and our collective public health. Thank you, and I'm happy to answer any questions you may have.
Dr. Jones, thank you. We'll continue with the other members of the panel before we open up the committee to questions. The chair recognizes, too, that we've been joined by Representative Emily Kincaid. Please.
Well, good morning, Chairman Williams, Chairman Heffley, Representative Madden, and distinguished members of the House Human Services Committee. My name is Sam Cook, and I serve as the Policy Director for the Pennsylvania Commission on Crime and Delinquency, or PCCD, as we are affectionately known. PCCD administers state and federal funds to support local initiatives, and we also bring together experts to tackle important public safety issues through our commission and our advisory committees. A key need that we often hear is preventing deepened justice system involvement, particularly for those with substance use disorders. Research shows that medication-assisted treatment in jails can reduce relapse, overdose, and recidivism rates, while also improving safety of facilities. We appreciate this committee's focus on this issue and the chance to share how we've administered treatment funding at our agency. PCCD has adapted our grant-making approach over the years based on feedback from counties and their medical providers, seeking increased treatment options as they navigate tremendous as well as evolving challenges. We think HB 561 will strengthen the state's investments in jail-based treatments and increase the impact of this critical program. And I'll now turn things over to my colleague, Michael Leister, who will be providing the bulk of our testimony this morning.
Good morning. My name is Michael Leister, and I serve as the State Crisis Intervention Program Manager at PCCD and oversee the agency's county jail-based medication-assisted treatment grants, including those supported by Act 80 of 2015. As Sam said, we appreciate the opportunity to testify today to provide an overview of PCCD's administration of Act 80 funds to date and share insights into House Bill 561. We know substance use disorder is widespread within the justice system. A decade ago, Pennsylvania's General Assembly had the foresight to pass Act 80 of 2015 into law, establishing a new grant program within the Pennsylvania Department of Corrections to provide funding for county jails for Vivitrol, a non-narcotic, long-acting opioid antagonist. Beginning in 2019, DOC entered a memorandum of understanding with PCCD to administer Act 80 funding, given our significant experience with providing grants to counties and local justice system initiatives. The majority of Act 80 funds are made available to support Vivitrol programs and are open to all 62 Pennsylvania counties with a county jail. To date, PCCD has administered over $9 million in Act 80 funding to 37 counties to support Vivitrol programs, serving 1,690 individuals since the program's inception. In 2019, PCCD awarded our first round of Act 80 grants to 16 counties through a competitive solicitation. The initial 2-year project period for these grants was extended multiple times to allow counties to fully draw down grant funds in the wake of operational challenges resulting from the COVID-19 pandemic. In 2024, we announced more than $7 million in new non-competitive formula-based Act 80 funds, guaranteeing funding to all 62 counties with jails. Ultimately, we awarded 32 counties requesting more than $3.7 million, about half of the funding available. And of note, 11 of those counties are new MAT grantees, expanding the footprint of Vivitrol to additional jails in mostly smaller, more rural counties. In addition to Act 80, PCCD also supports jail-based MAT programming through 2 federal funding streams, the Residential Substance Abuse Treatment Program and the State Opioid Response Grant. Unlike state funds, both federal funding streams support all forms of FDA-approved medications, including Vivitrol. Our written testimony provides additional details on these funding streams and their reach. One of the consistent themes we've heard in our work with counties is the need for flexibility. We know jails face a lot of hurdles when it comes to operating these kinds of treatment programs. We've also observed a strong demand from counties for options when it comes to the medications and related costs dollars can pay for. To that end, PCCD has seen an uptick in interest from counties who want to use available funds to support the full scope of FDA-approved medications in their jail-based MAT programs. As an example, during our last Act 80 solicitation, PCCD fielded questions from multiple county jails inquiring if the funding could support county jail-based MAT programming beyond Vivitrol. As stated earlier, PCCD supports House Bill 561 because it will address many of the challenges and barriers that we've heard from county jails. The bill provides more flexibility on how funds can be used, something we know our local partners are eager to see, and something we think will help appropriated dollars be more fully utilized. Specifically, House Bill 561 would allow funds to be used to purchase additional forms of medication, as well as cover other costs necessary for a jail-based MAT program, like training, personnel, and infrastructure. House Bill 561 will also expand access to critical resources in county jails for people who may benefit from more diverse treatment options. Finally, we appreciate that the legislation would keep this grant program within PCCD rather than Department of Corrections to streamline the administrative process. We applaud the General Assembly's leadership and commitment to increasing access to substance use treatment and its recognition that providing resources for jail-based treatment can pay dividends for individuals and their communities. Thank you again for the opportunity to present this testimony, and we're happy to answer any questions you may have.
Thank you so much. I appreciate the testimony of our panelists. And right now, what I'd like to do is ask our members if there are questions that you'd like to ask. Again, if you will compress your questions and refrain from general comments, it would be appreciated. Questions from the committee? Representative Flick.
Thank you, Chairman, and thank you, Representative Madden, and also to the testifiers. A few years ago, we approved something called the Stepping Up Initiative. I don't know if any of you recall that. And the intent of that was to provide grants and funding to each county. In our county, Lycoming County, we did MOUs to connect mental health to drug and alcohol to prisons and then gather that data. And the intent really was to check on recidivism. So I guess my question is, I don't know how many county prisons, but is there a mechanism that we could do something similar, but data collection? And I'm by trade a data analyst. And to be transparent, I wrote the Stepping Up Initiative software for a number of counties. Is there a mechanism that connects all of the county prisons together so we could track the medications per inmate, so we truly could check to see the number of overdoses afterwards and the number of recidivism, if that makes sense? So, thank you.
Thank you for that question. So we do support the Stepping Up initiative through PCCD. Unfortunately, there is no general mechanism for collecting broad county jail-based data. I believe across Pennsylvania's 62 counties, there are 11 or 12 different systems of record. So there's no way, unfortunately, for us to collect all that data. Through the grants, obviously, we require every county jail-based grantee to report to us on a quarterly basis. We collect everything from the number of people served, number of staff trained. We have a long list of data points that we do collect. We do have in-house staff that can process recidivism data, specifically for the folks that we serve through grant funding. But unfortunately, when looking at the broader scope of the system in county jails, we currently don't have that capacity.
All right, I appreciate that. I do think it would be incumbent on us to try to get one system approved, or at least something at the state level that those 8 or 9 systems uploaded data that was consistent so we could track this. Thank you, Mr. Chairman.
Thank you. I also want to recognize that Representative Venkat has joined us. Dr. Jones, let me offer a question for you. County jails, could they integrate MAT programs into their general medical services budget instead of relying on grant programs?
I'm not sure whether or not they could put that into their general budget, but what I can say, some jails have decided to do so. They contract with an outside organization to administer medications for opioid use disorders, but I can't speak for every single county because, as you know, across Pennsylvania, each and every county is truly unique. Thus the reason why we have this program, so that counties that do have perhaps funding restrictions, they have the opportunity to apply for these funds so that they could at least, at minimum, offer what's currently allowable today.
Thank you. Thank you. Representative Kincaid.
Thank you, Chairman. This is probably more for PCCD. Can you talk about the fact that despite the fact that Act 80 funding is available, the demand from counties actually remains pretty low? What factors do you think are contributing to the underutilization? And then also, what practices could jails implement to address security concerns and minimize diversion risk with MAT programs?
So in terms of factors, I mean, obviously, I think the COVID-19 pandemic played a huge role in the amount of funding that we do have available. Also, the influx of additional funding at PCCD through those 2 federal funding streams that support all 3 forms of FDA-approved medication. Again, we put a non-competitive formula-based funding solicitation out last year with guaranteed funding for all 62 counties and only had 32 counties apply. We did receive multiple questions from counties about flexibility of funds, if they could be used for things beyond Vivitrol. But unfortunately, based on the Act 80 legislation, that is not the case. And the second piece of your question, I'm totally blanking. If you could repeat.
So I just want to clarify one thing. So is it they're not participating because there's just not flexibility in the funds? Is that kind of
some county jails don't have a current need for Vivitrol funding. Either they already support it through county funding, through other grant funds, or they just don't have a demand for Vivitrol within their county jail.
Okay. The other part of my question was, what best practices could jails implement to address any security concerns or diversion risks with MAT programs?
Sure, and I would just preface that I'm not a jail administrator, not an expert in the administration of MAT either. But I think in terms of best practices, it's having procedures and protocols in place for medication administration. The greatest risk diversion, obviously, is typically with buprenorphine and oral versions. I think if a county jail has procedures and policies in place where they're observing that medication administration, ensuring that the mouth is clear before participants are returning back to their resident, I think that would be the best practice in that situation.
Thank you. Chairman Heffley.
Thank you, Chairman. First, part would be for PCCD. So last year, was $1.75 million was set aside for Vivitrol. Just to clarify the program, were all those funds used, or
No, so PCCD issued a solicitation back in 2019 where we awarded just over $5 million. That round of grants, because of COVID-19, other factors, were extended multiple times. We also released various other federal funding solicitations during that time, where we observed a decreased demand for county jail-based MAT dollars. So we made the decision to not release Act 80 dollars because there was other funding out there to support jail-based MAT programs, and we had an influx of dollars coming in. So the most recent $1.75 million has not been spent. We have a balance of, I believe, about $7 million, and that's after awarding that $3.7 million last year.
Is it not being spent? Is the Vivitrol program? Vivitrol is a very specific type of treatment, much different than Suboxone or methadone. It's non-narcotic, and I think the grant program is initially set up for that specific purpose. So I'm curious as to why it's not. Is it something that is being underutilized, or is it not being promoted enough? And is anybody being denied other MAT right now because of these dollars aren't accessible, I guess?
I can't speak to that 100%. I mean, I can tell you that there was a settlement in 2023 between Allegheny County and the U.S. Department of Justice, where the Allegheny County Jail was accused of withholding methadone treatment. They now have a settlement with the Department of Justice under the previous administration that they will provide all three forms of FDA-approved medication in an induction as well as a continuation status. So I think in terms of Vivitrol, in some county jails, they do a great job of promoting. There's a lot of demand. I think in other county jails where other forms of FDA-approved medication are available, Vivitrol is not in high of a demand. Philadelphia, for example, has the most robust buprenorphine program maybe in the entire country. And they offer very little in the way of Vivitrol just because there's not a demand within the county jail. So every jail is going to be different. We want to have the flexibility to be able to offer all forms of medication within all jails. And again, as the secretary said, allow that decision to be made between the physician and the individual who's participating in treatment.
Just one more question for Dr. Letitia Jones. With the Vivitrol being very specific, and the funding, obviously there's federal funding streams. I guess my concern is because it is a specific type of treatment, it is, if we take away, say that these particular dollars, 1.75, that's allotted every year, million, compared to all the federal dollars that come in from MAT and everything else. If we take that specific point away, and this is just to be clear that we're still going to be promoting Vivitrol because it's a very specific type of medication, and somebody I fully understand that when we see people overdosing when they come out of prison, and it's horrific, and Vivitrol can help that. So if we're going to open these dollars up, I just want to be sure that Vivitrol is still going to get the same priority as everything else for those individuals that are ready for it.
Yeah, absolutely. I think what we've said this morning is that we want jails to be able to have the opportunity to prescribe all three medications, and that the decision on which medication should be prescribed, that should solely rest with the clinician, the physician, and the patient, right? And so we're not saying that Vivitrol should be removed from, the offerings to inmates. And in fact, I think that inmates need to be clearly educated on each form and thinking about what form they should go on as a result of thinking about when they are released, right? Just based on some anecdotal information, many individuals that are prescribed Vivitrol, once they leave county jails, many of them do not follow up for follow-up appointments. We know that it's very costly as well. I don't know if PCCD has a figure about it. I remember it used to be very costly for Vivitrol as well. So that may be some of the factors of why individuals aren't choosing to be put on the specific medication as well.
And just real quick follow-up, and I know we want to keep moving, but so if somebody is leaving the prison system, and they generally, if they leave the prison, they'll be signed up for MA, correct? So with this Vivitrol grant, if somebody is leaving the prison system and they're still under supervision, like through parole or something like that, would the Vivitrol then be available for them?
Ideally, if the person is signed up and their Medicaid is turned on.
Mm-hmm.
And if not, if their Medicaid is not cut on, if they are, let's say, receiving case management services and referred to a single county authority, that could be an option for payment as well. But as we know, when folks leave the jails, many of them are often challenged with keeping those services that they had in the jail, keeping them after they're released.
And I know we've had a lot of overdoses in county prisons.
Mm-hmm.
I don't know if there's a report how much that could have been like through prisons that operate an MAT program with Suboxone and methadone. We've had several overdoses with both of those products throughout the Commonwealth. But can any of these funds be used to help those county prisons that are going to maybe implement an MAT program to make more secure measures, or is this just strictly used for the medication, or could it be used for them to help set up a program to administer it?
Sure, yeah, the funding can be used to support multiple aspects of the program beyond just medication. So staffing on the medical provider side, but also on the corrections staff side. Can be used for training purposes for staff. An important part of a medication-assisted treatment program is also the cognitive behavioral therapy piece. So supporting that piece of the pie as well. So generally for Act 80, but then also for our other federal funding streams, those dollars can support broadly the MAT program and aren't just specifically for the medication.
Thank you, Chair. I'm going to ask Representative Serrato if she would be the last question right now for this panel. And as always, to the members of this committee, if there are additional questions that you have, feel free to submit them to Imogen or to Anne Marie, and we'll get responses as quickly as we can. We've also been joined by Representative Harris. And for the final question, Representative Serrato.
I'm actually going to make this easy. My question was already answered, so I can waive off. Thank you.
The chair thanks the lady. I want to thank this panel for your presentation. Thank you so much.
Thank you.
Moving on to our next panel this morning, I want to invite them to the table and to the microphones. Today, we're joined by Su-Ming Ye, Executive Director of the Pennsylvania Institutional Law Project, Dr. Kyle Kopko, Executive Director of the Center for Rural Pennsylvania, and representatives from the Pennsylvania Association of County Drug and Alcohol Administrators, James Egler, Michelle Weller, and Heather Franzoni. Let me remind the panelists, if you can, to truncate your remarks, give us the salient points of your work. Bring the microphones close to you, if you would. Speak right into them. And I'm going to begin with the Executive Director of the Pennsylvania Institutional Law Project, Su-Ming Ye.
Good morning.
Good morning.
Good morning, Chair Williams, Chair Heffley, Representative Madden, and members of the Human Services Committee. Again, my name is Su-Ming Ye. I am the Executive Director of the Pennsylvania Institutional Law Project, and thank you very much for this opportunity. And we've submitted written testimony along with my colleague, Sarah Bellows. The Pennsylvania Institutional Law Project is a nonprofit legal aid organization, and we seek to protect and advance the constitutional and civil rights of people who are incarcerated and detained in Pennsylvania. But specifically, what we seek to do is ensure everyone is treated humanely, that they have access to medical care and mental health care, that They are safe from violence and sexual abuse and have the ability to observe their religion and have their disabilities accommodated while they're incarcerated. So I want to just give a few highlights because I know I only have 5 minutes. Starting with a client of ours. So we give some statistics in our report, but the human face of this is an example by Sean Strickland, who has struggled with opioid use disorder since he's been a teenager, starting off with Percocets. His story is very similar to other folks. Finally reaches some stability on a daily methadone program, and then unfortunately is arrested for some supposedly not appearing for a hearing for unpaid costs and fines. Gets arrested, and unfortunately the county jail here where he's at has no program for methadone or buprenorphine, so he is forced to withdraw. It's extremely painful. Something I've learned is that it's actually very painful to withdraw from methadone. And on top of that, even after he was released about 6 weeks later, he is experiencing post-acute withdrawal syndrome because you can't just get back onto methadone when you're released. And to his credit, he goes very soon, like the next day or 2 days, he goes back to his methadone program. But you have to titrate back up to your what's called therapeutic dose. And all that time, he is suffering. We're in touch with him, and I'm worried about him because he's not getting what he needs because it's too dangerous to go right away. And so he's experiencing cravings and all the symptoms of opioid use disorder. He is an example of why all county jails should offer all 3 forms of FDA-approved medications. While many jails through the programs, it's a first step to offer Vivitrol or naltrexone, the medical community, out in the community, many people, and most people, in fact, are prescribed buprenorphine and some methadone, especially with the increased use of fentanyl and the use of xylazine in the drug supply, and now I've heard about medetomidine. It's really critical to be able to offer buprenorphine and methadone because of the potency of these drugs. And sometimes the reason why it's important is because sometimes naltrexone just doesn't work for folks. We've had a lot of clients who've tried it in jail. They are desperately trying to stabilize themselves and get on the right path, but it hasn't worked, and so therefore they are trying to get access to buprenorphine. And what they're trying to do is just seek feeling normal. So we've heard a lot. I think there's a misconception about, for example, buprenorphine. Oh, people are just getting it, using it to get high. Or our clients countlessly, constantly tell us it's not to get high. It's really because it makes me feel normal. It makes me feel like I can function like a human being. So in 2022, we decided to issue a report looking at every county jail and what their policies and protocols were in the access to medications for opioid use disorder. And since then, the landscape then evolved due to various reasons. It's funding, litigation, pressure from the Department of Justice, and ever-changing, community sentiment as well. And so in 2024, we did an update, and I believe that we had mailed a copy to each representative, state representative, state senator, with the latest report. In our testimony, we have a slight update on our map. And so while there has been progress forward, I want to emphasize the huge gaps that still remain and the very important gaps. So just to highlight for today, currently still 16% of jails do not provide any mood, or they only provide it in very limited forms or limited amounts, or to limited people. The other issue to highlight is many jails, as they start providing it, start with what we call continuation. Someone comes in with a prescription and they're continued on that. That is important because that prevents someone from withdrawing from a particular medication and keeps them stable. But just like someone who comes in, let's say you find out they have diabetes or hepatitis C or they're pregnant, the jail is obligated constitutionally and under the medical standard of care to provide medications and medical treatment for them. The same thing is here. So we call that induction. And currently, 73% of jails still do not have an induction program. And then the last gap that I just want to highlight is the gap of methadone, which admittedly there are different logistical challenges in administering a program, but it can be critical for many people. And 33% of county jails still do not provide methadone. And then the other point, I just want a couple points to emphasize is one is there are also challenges we hear from individuals, even if a jail does have a program. So, you know, we heard one jail was handcuffing people while they had to get the medication or giving the medications like at 2 a.m. So I understand the challenges in administering this, but we must do so in humane ways. And then we also get reports of people being removed from these medications for non-medical reasons. And I think that's in part due to stigma and a misunderstanding. People who seek to have their medication are blamed for being addicts and trying to get more drugs, but it's not. It is a medication and a medication that works. It is also required by the Constitution, required by federal and state law. Thank you very much.
Thank you. Dr. Kopko.
Thank you very much, Chairman Williams, Chairman Heffley, members of the committee. Happy St. Patrick's Day to everyone. My name is Dr. Kyle Kopko, and I have the privilege of serving as the Executive Director of the Center for Rural Pennsylvania. Many of you probably know that the Center is a legislative service agency of the General Assembly, and we serve as a resource to all members of the House of Representatives and the Senate as a data resource, as a means to craft policy that affects not only our rural communities, but also our urban communities throughout Pennsylvania. We have two main legislative charges. One is to provide a grants program to our faculty members at state universities to conduct applied policy research on the General Assembly's behalf. And then we also maintain a comprehensive database of statistical indicators that affect rural and urban areas of Pennsylvania. And I'll be drawing from that database for much of my testimony here today. Just very briefly, I wanted to discuss, first of all, the Center for Rural Pennsylvania's history of hosting legislative hearings on the substance use disorder crisis and the opioid crisis, particularly in rural Pennsylvania. Some ongoing research that may be of interest to the committee, which will be released later this year, and also our analysis of some general trends in the overall population, but also some information that's germane to correctional institutions and incarcerated individuals. First of all, I should note, because of the leadership of our chairman and vice chairman, Senator Gene Yawn, Representative Eddie Day Pashinsky, the Center for Rural Pennsylvania this past October held its 20th hearing over the past 10 years just on the substance use disorder crisis and the opioid crisis. I think my predecessor at the Center for Rural Pennsylvania, Barry Dank, was instrumental in pointing out that this is not strictly an isolated problem for any particular part of Pennsylvania. This affects rural communities. It affects all parts of Pennsylvania. We've heard time and time again over the course of these 20 hearings, anything that could be done to reduce stigma so that individuals can seek treatment and also expand the use of MAT or MOUD, depending on your preferred terminology, would be useful for saving lives. All these hearings, testimonies, video recordings are freely available on our website at rural.pa.gov. And if anyone needs additional information about any of these past hearings, please let me know. I'd be happy to forward that on to you at any time. Through our grants program with faculty at state universities, we are currently partnering with Dr. Christina Brandt, who is an assistant research professor of rural sociology at Penn State, on a study that examines statewide access to evidence-based treatments. We expect this report to be out by the fall of this year. Dr. Brandt is surveying every single SCA, every opioid treatment program in the state, to better understand how they serve communities across the Commonwealth. She is also in the process of interviewing stakeholders, MOUD providers, as physicians, nurses, counselors, criminal justice professionals, including staff who work in jails, treatment courts, and other individuals, harm reduction groups and organizations that provide test strips, naloxone, and other services, and also service users, individuals who are in recovery and using MOUD. When this report is completed later this year, we will be able to produce graphics and maps that provide a wide range of information, including the number of MAT or MOUD providers in rural counties, methadone clinic locations and their numbers, harm reduction services available from SCA, syringe exchange locations where available, first responder use of naloxone, treatment court availability and service provided, and MOUD services in prison. So look for that later this year. and I'm sure that Dr. Brandt would be happy to have a conversation with any members of the committee. In addition to my written testimony here today, I also produced a number of data visualization graphics in cooperation with our staff. To start with, we provide what available information we have access to on the number of individuals standardized by population in rural and urban areas with substance use disorder, including those who are on medical assistance. We also provide information on the distribution of buprenorphine. But I think that this committee may be most interested in information on overdoses and also substance use disorder among incarcerated individuals. While we have made progress in decreasing the number of overdoses in this past year, they are still relatively high. In our urban counties, there's 4 overdoses per 10,000 individuals, whereas 3.2 overdoses per 10,000 individuals in our rural counties. And unfortunately, those who do not survive an overdose, it's tragic either way, but in our rural communities, the rate is higher than it is in our urban areas, most likely due to lack of treatment facilities, distances to hospitals, doctors, and similar medical services. On our 14th slide, we provide information from 2016 through 2021 based upon Pennsylvania Department of Corrections data, examining the the percentage of incarcerated individuals, newly admitted inmates who have opioid use, 38% in rural, 27% in urban. That's just for new admissions to our correctional institutes. The percentage of overall admissions diagnosed with an SUD program, 81% in rural, 70% in urban, and the percent of admissions who have used an opioid within the last 12 months, 42% in rural and 29% in urban. We also go on in subsequent slides to break down the economic impact of those who experience substance use disorder due to lost wages, loss in taxation. I think one of the key takeaways is between 2016 and 2020, Pennsylvania lost $13.7 billion in wages because of substance use disorder, and just over $420 million in state income tax due to opioid use. This is just a sampling of the types of data analyses that we can provide for members of the committee. If there's anything that my staff and I can do to be of assistance, please don't hesitate to reach out. I'm joined here today with our communications manager, Katie Park, and our research fellow, Shavi Mishra, who's a senior at Franklin and Marshall College. This is her first legislative hearing. We're all happy to be of assistance in any way that we can. Thank you very much for your time.
Dr. Kopko, thank you so much. I'm going to move to our representatives from the Pennsylvania Association of County Drug and Alcohol Administrators. I'm going to begin with you, Mr. Egler.
Thank you, Chairman, members of the committee. Thank you for the opportunity to testify today. My name is James Egler. I'm administrator for Franklin Fulton Drug and Alcohol Program. It is an honor to speak before you on the behalf of the Pennsylvania Association of County Drug and Alcohol Administrators, PACTA, which represents the single county authorities, SCAs, responsible for administering substance use prevention, intervention, treatment, and recovery-oriented services across the Commonwealth. I'm also joined today by Franklin County Jail's Warden Heather Franzoni and Deputy Warden Michelle Weller, who can speak firsthand to the needs of incarcerated individuals and the importance of access to treatment in county jails. For me, this discussion is personal. May 2nd of this year will mark 11 years in recovery. Looking back, if you had told me a decade ago that I would be working in this field, leading an SCA, and speaking before the Pennsylvania House Human Services Committee, I wouldn't have believed it. My journey began at a moment of crisis. Like so many struggling with a substance use, I sought help from a doctor, not knowing what options were available. Thankfully, I was provided the choices, including access to FDA-approved medications for substance use disorder. While I can't say that the medication alone brought me to this moment, it provided stability. I needed to engage in treatment, to heal, and to build a life in recovery. That stability and the ability to focus on treatment instead of withdrawal and cravings was essential to my success. While my story took place in the community, the same opportunity should be available to individuals in county jails. When someone suffers a heart attack, we don't withhold treatment until they improve their diet and exercise. we stabilize them first. The same should be true for substance use disorder. Naloxone save lives in the moment of an overdose, but FDA-approved medications, buprenorphine and methadone in particular, are frontline treatments that reduce overdose deaths, improve engagement in care, and ultimately give people a fighting chance in recovery. Research has shown that providing medications for SUD during incarceration significantly reduce post-release overdose deaths and increases treatment retention. However, Pennsylvania County jails are currently limited by Act 80, which allows only one medication, naltrexone. While naltrexone may be an appropriate option for some, it requires full detoxification before initiation, making it a less viable option for many individuals in withdrawal. When treating a severe illness, we don't start with the least effective option. We turn to the treatments with the highest success rates. If an individual enters jail with cancer, we don't limit them to a single less effective medication. We provide them with the full spectrum of medical options proven to save lives. Expanding access to FDA-approved medications for SUD ensures that incarcerated individuals receive evidence-based care tailored to their needs, just as they would in any medical setting. SEAs play a critical role in funding and coordinating substance use treatment across our counties, including in correctional settings. While opioid settlement dollars have helped some counties establish MAT programs in their jails, funding levels vary drastically. Some counties receive millions in opioid settlement funds, while others receive only tens or hundreds of thousands. Funding that is often front-loaded and inconsistent year to year. Counties and SCAs need stable, ongoing funding sources to ensure MAT programs are not only established but sustained long-term. I cannot say enough about the support I've received from my PACTA colleagues, who are not only my peers, but mentors and leaders in this field. I encourage every member of this committee to reach out to your county SCA administrator director. They know the needs, they know the gaps, and they know the impact that expanding medication for SUD in jails, in the jails we have. Thank you for your time. I appreciate the opportunity to share my perspective, and I look forward to answering any questions that you may have.
Thank you, Ms. Weller.
Good morning to the Human Services Committee. My name is Heather Franzoni, and I am the warden at the Franklin County Jail. It is an honor to speak in front of you today. My job as warden ultimately is to provide care and custody and control of those in our custody. It's our job as correctional professionals to take care of their physical, emotional, and mental health while they're in their care. Most of the individuals incarcerated will ultimately be released and be all of our neighbors, our coworkers, and our children are going to play together on the playground. It's important in our system to provide trauma-informed treatment and provide treatment-based MAT. This House bill amendment will ensure that I can continue to offer a choice to those in our care. As most of you may know, there is legislation, and currently it's an ADA Act, and of course, if we don't have the funding, we also face certain other litigations as far as county corrections. I also heard a lot about diversion attempts, and if you don't know anything about a warden or anyone in corrections, we always have yellow notebook paper, and we're probably not that prepared. So I was jotting down notes as I was listening to some of the questions, and there was a question about diversion attempts. And I think as diversion attempts, the simple answer is you allow the correctional facility to prove you that we can do it. It's a security procedure. We have policies in place to prevent diversion, and advantages greatly outweigh the obstacles. Currently, our MAT pass is just another day in the office for my staff. They get up every morning. Our staff start MAT pass at 3 o'clock in the morning, and it's honestly just another day in the office. All our participants have drug and alcohol treatment, warm handoff, and support both inside and outside the walls. So MAT isn't new to us. We've been doing the Vivitrol and other forms of MAT since 2017, and I think it'll help you to see that it can be done and what success rate that it has. I'm going to pass it off for the sake of time to Deputy Warden Weller to give you just a little insight on our program that's been going on since 2017. Thank you.
Good morning, and thank you, members, for giving me the opportunity to speak with you today. And as Warden Franzoni said, I wanted to give a little bit of specific details about our program and the success we've had, as well as some of the obstacles we faced and how we've managed them. So at Franklin County Jail, all of our new commitments are screened for the need for detox protocols. At this time, 30% of all commitments come in with that need. We use a TCU drug and alcohol screen that looks at the drug and alcohol use within the last 12 months, helps us identify people that are interested or in need of drug and alcohol treatment. And at this time, 75% of the people screened would benefit from services. So as far as the jail to community treatment program, which is what we call our program, we started it in 2017 offering just Vivitrol. In 2020, we moved to all forms. We found that we had greater participation when we offered all forms. We saw the benefit that every patient's going to be treated as a separate individual, and what would work for one might not work for the other. What we did keep consistent, though, with all people that were receiving the MAT was that they had access to our mental health clinicians that were also certified drug and alcohol counselors. We provided case management support and the warm handoff so that when they left, they knew where they were going to be able to go to continue their treatment and their medication. We handle ours with our medical department, as I said, with the mental health clinicians, and they work with our custody staff on a daily basis to distribute those medications, and as Warden Franzoni said, to identify any risk of the diversion as well as prevent diversion attempts. So again, this is something that we have managed. It's something that the diversion is something that we anticipate and that we've been able to successfully kind of handle, I believe. So, and I would open up for any questions.
Let me just say thank you to each of our panelists. Thank you for your insights today, and open this up to our committee for questions. Representative Flick.
Thank you, Chairman. Again, thank you to the testifiers. Of all the data, Doctor, thank you for all the data. All the data I've heard, the most impressive is James, 11 years. So congratulations on your recovery.
Thank you.
You are proof of what can happen. So thank you. So I've actually, again, to be transparent, done a lot of work in Franklin County for a couple of decades. And the relationship that you have with the warden is phenomenal. My recollection is you guys are about 10 feet apart, right? The buildings that you work in?
The old facility.
You moved since then? Okay.
Yeah.
So what are the problems? We talked about the 16% of county jails that do nothing. Can we just be honest and frank here? What's the oversight? If somebody's doing nothing to help the Jameses of the world, something needs to happen. So it's, again, Franklin doing a great job. Michelle Denk with PACTA doing a great job. But where's the oversight of the county prisons that are doing a terrible job? If anybody wants to answer that.
I feel like I can answer it as a broad statement. Just as a warden, we're overseen by our county commissioners, and we also answer to a prison board, which is made up of elected officials, whether it's president, judges, county commissioners. So I think that I can't speak for any specific county, but that's kind of where you could look to. That's who I report to. That's my oversight and kind of how I'm guided into my decisions and what's best for our population.
All right, thank you for that. I think that presents one of the issues, and that is that county commissioners, most of them are not experts at this topic, and they revolve every 4 years. So there's a CCAP meeting tonight, so hopefully I'll get to talk to a lot of county commissioners. Thank you, Chairman.
Thank you. Are there any other questions from the committee? Representative Harris.
Yeah, good morning. Thank you for your testimony. What's your, do you find it difficult to connect the dots? Like, as far as an incarcerated person to a person that's leaving, the young lady spoke about sometimes people don't do the follow-up. And also, what about a level of, with the correctional officer and the person that's going through anxiety, things like that, what's the patient level that, to get a little bit of understanding that, I know, you have to adhere to some commands when you're incarcerated, but if they're going through withdrawal, or I'm talking about an end to their recovery or in the treatment, what's the level of just being I guess a bit of understanding?
I think I could speak for our correctional staff. And I don't know who you were directing that question towards, all of us, or? Okay. I could speak for our correctional staff. They're all trained and trauma informed, which is required now. And I think that they all carry a sense of empathy and compassion no matter what the individual is going through. They are notified if someone's going through detox. They know the individuals who are coming in and are on the MAT program. No one is treated differently. I think that they come in and they are correctional professionals. They treat everyone the same, but they might have to, we have what's called direct supervision. So not all county jails are direct supervision, but we're granted to have a direct supervision housing unit. So those officers are on the housing unit with the inmates. They're getting to know them. They're getting to know their bad days, their good days. They're getting to know the changes. That is huge when it comes to lowering the risk of suicide, helping those who are detoxing, helping those who are just having a bad day. So while I think every warden would say they have the best staff in the state, I would say I think I have some of the best staff in the state. I have seen these individuals spend 15, 20, 30, 45 minutes with just one individual just to try to help re-guide them, help them in crisis situations, whether it's mental health, detox, or just a bad phone call. And I think I could speak for a lot of wardens in the state of Pennsylvania that they have the same staff as well.
I'm just going to jump in with some anecdotal evidence, which I think it does vary widely. And it is this, what you raise is critically important. So unfortunately, maybe because we are a legal aid organization, we get all the complaints. We hear the bad stories, if you will. So unfortunately, we do hear from a lot of people where, it's a corrections officer who's the one calling them names, calling them out, saying that you're not on medication, you just want drugs. And I think that a lot of the education needs to happen on all levels. Good leadership is important, and education and training, and having a sense of understanding and empathy for those who are struggling with substance use disorder is very important. And then the corollary to that we sometimes hear are complaints that someone's been accused. Sometimes, our clients reach out and say, "Hey, I wasn't doing this," but accused of diversion. And so on this issue, if someone's accused of diversion, we have to look at the medical need. And from our perspective, there are ways to decrease it, the incidences, but there's also the possibility of moving someone to an injectable. So different jails have different techniques of addressing diversion, but removing someone because of an accusation or even, getting a misconduct for something completely unrelated, those should not be reasons to be taken off the medication. And part of that is understanding this is medical treatment, and you can't take away medical treatment as punishment.
Right. Thank you very much. Because I think James, as long as the dots are connected, we can combat recidivism. So because we have to understand they are incarcerated individuals, but with needs. So if the dots are connected, it could be a better society when they get out. Thank you.
Thank you, Representative, and thank you for your insights and your expertise today. I'm going to close our questions out at this point, but I'm going to invite Representative Madden to the table and allow her to share her remarks as the sponsor of the legislation that's at the center of today's conversation. Again, panelists, thank you so much for your insights.
Good morning. Chairman Williams and committee members, Chairman Heffley, thank you so much for this hearing, this very important hearing. The experts have described my bill in real great detail, so I just want to close with some of the words that I heard today over and over again, right? Empathy, humanitarian. As representatives, it is our obligation when people come into our county jails to treat them like human beings. By the time they get to our county jails, they've hit rock bottom. They've absolutely hit rock bottom. They have nowhere to go. They're looking at incarceration. And most times, as we've heard, they want to be clean. They want to go through jail. They want to get out, and they want to be productive members of society. And it is incumbent upon us as representatives of the people to make sure they have every opportunity to get sober, to get clean, and to stay that way. And we know the success rate is over 77% when we allow people alternative treatments to opioid addiction. We know that the money is there. We know that their use of naltrexone is underused because people are choosing alternative treatments. We know that everybody's brain functions differently, so what works for one person doesn't work for another person. It is our moral obligation that when people are in our jails and they are looking for help while they're looking to serve their time, that they come out clean and they come out with a program and they're able to continue, because the stories of people who come into jail on treatment programs and have to go through 48 or 72 hours of withdrawal because there's no system in place like there is from the Warden Franzetti and Deputy Warden that we heard. It's incumbent upon us to make sure those programs exist in each and every one of our county jails, and for us to look at the evidence that we got where, what's rural and what's urban, and where we're serving people and where we're not serving people. And to your question, Rep. Flick, I don't know if this answers it, but upon enacting this bill, there will be a biennial report to the Senate and to the House showing the success and where this program is going. So that's really all I have to say. I thank you all for talking about this bill. It did pass 199-4 in the last session, and hopefully we'll pass it again, and the Senate will see fit to take it up. But thank you for your time. I appreciate it.
The chair thanks the representative. Let me just say, by way of closing remarks today, again, a heartfelt appreciation to Representative Madden and to all of you who participated as panelists today, and to my fellow committee members for their thoughtful questions and responses. Obviously, the marriage of expertise and empathy has been clear throughout these hearings. Today's discussion has made it clear that Pennsylvania must do more to expand access to all FDA-approved medications for substance use disorder. When the committee meets again to consider this legislation, we should remember that this is about more than just treatment. It's about saving lives. It's about reducing recidivism. It's about supporting long-term recovery. Individuals struggling with substance use disorder deserve the same standard of care as those with any other chronic disease. And so, having said that, again, thanking you for your testimonies today, I'm going to allow Chairman Heffley to have final comments.
Thank you, Chairman. I thank all the testifiers today. It was a very enlightening testimony. And obviously, we want to make sure that people that struggle with substance use disorder are getting the treatments that they need. At the moment, when somebody interacts with the criminal justice system, that really is a point where there is an opportunity, whether it be through diversionary programs like drug courts, or if they're going to be in a prison system, to get them the treatment that they need. Want to make sure that we're accessing and are available for all the treatments, and also that we have an eye on what's coming up, because the drug trends continue to change. So I thank everybody for being here today and had a really good discussion, and I thank Chairman for conducting the hearing.
Again, thank you for your insight. Thank you for your passion. Thank you for your commitment to such a critical issue. This meeting is now adjourned.